to record the sessions going forward to ensure that we have availability to reference these back in the future. We are very excited to have this as be our first meeting of launching the Quality Leader session. We've transitioned from office hours into our leader session and look to you as our body of interest to help us determine what's going to be most beneficial for us going forward as we look to future sessions. So please share that information with us. Let us know what's important to you, what keeps you up at night, and we'll look to get some resources in place as the speakers in place to work that through. As we go forward, we will continue to talk about what's happening with COVID. This continues to be an area of opportunity for us, something that drives what we do from operations perspective and helps us to stay focused on changing updates. We'll share that information with each other, as well as any best practices that have been developed, as well, and then talk into some of our new points of interest that are coming through from an operations perspective. Today's session is going to be reviewing the survey readiness and digging into infection control, as well as some QAPI tools, just to help us be ready. Building off of last week's conversation with DHIC regulatory officials, they did a fantastic job giving us some basic information. And so we're going to continue that conversation today, discussing how we can ensure that survey readiness is in place and what tools we have available for us. As we look ahead, we have looking at our vaccination status by state here in South Carolina. We're still averaging about 46% up-to-date status, including the bivalence. The data from the current nursing home spread rate is still from last week. It wasn't updated as of this morning. I anticipate we'll get the updates later on this week from NHSM. But happy to see that sharp drop that we have coming down and hope that that continues forward for all of us. For South Carolina, the COVID community level, we're seeing some positive things happening in, excuse me, transitioning from oranges and yellows into greens. And so some good things happened this week that we're pretty proud of in continuing that decline. But an area of opportunity that we wanted to include going forward was the community transition rate. So if you recall from the QSO memos, QSO was directing us to look at the community transmission rate and determining what our rate of spread is and what we should be doing, considering doing from a preparedness perspective. And so in this case, we do have a lot of South Carolina still in the high transmission and substantial transmission areas, which leads us to look at our policies, thinking about when do we implement mask use, when we're going to be looking at educating our staff, possibly even looking at increasing sanitation of high-touch surfaces. It kind of keeps us in that moving forward focus on preventing and mitigating any spread from activity happening in our communities. So we will include this graph going forward just to keep us up to date on what's happening with that community transition. And for your information, that is available to us on the CDC COVID data tracker. You will have to go up to the MAP metric and drop it to community transmission rates. This is something as an administrator I failed to do frequently. I was usually too happy and excited to see our COVID rates change and our colors change on the graphs that I didn't always go to that next step. So you want to make sure from a QSO perspective and compliance perspective that we are making that transition and recognizing that. Our hospitalizations reported off of the COVID data tracker continue to show a decline. And again, hoping that we came out of the holiday transmissions with low rates and we can move through this. So a couple of pieces as we look forward is really thinking about how do we ensure that we are compliant and survey ready. And our presenters last week really highlighted the impact that we should be survey ready at all times. And it's great in practice, and it's not always easy to operationalize that. So I ask, do you have any recommendations? Do you have any ideas on how we can be survey ready at all times? If you'd like to put them in the chat box. Or unmute yourself and jump in. I think this is important that we think and talk about what does this look like? And how do we make sure that this is something that we keep on the forefront as we look forward? Do we have any ideas or suggestions on how we could be survey ready?
The biggest thing that helps us is rounding. And when you see something out of the way, instead of just writing it down, do some education right there on the unit in front of everybody.
Oh, that's a great idea. That's fantastic. It's also, to your point, what a great opportunity from a staff engagement perspective to have tokens or a celebration or a candy bar in your pocket, that when you find someone that's doing really good with something, to recognize them and say, hey, great job, Alyssa. You did your med pass completely to standards of practice, and I just want to thank you for that. And do you have any tips to share with us on how you can keep organized? That's a fantastic point, Elizabeth, to keep that moving forward and doing those rounds. Thank you for sharing. Anybody else have any thoughts or suggestions? I had a supervisor that encouraged us to think about how are we using our survey pathways in our QAPI program, and how are we utilizing those to do an ongoing review every year to stay survey ready. And she had given a suggestion of creating a calendar and looking at all the survey pathways that we have, because we know that's what the surveyors are going to be following when they come through, and mapping out who could be responsible for doing the assessment and at what timeframes are we doing these, and including that into our QAPI meeting. And so, February may be infection control month, but then we also may do the infection control survey pathway in October, coming into influenza season. And so that we have that mapped on our calendar, and our ICP and maybe our unit manager would be responsible to taking the lead on that, to complete that as part of the assessment and bring that to QAPI for conversation of areas of opportunity. Whereas as the administrator, maybe June was the QAPI review. I had a teammate at another building that even took it a step further and said she was going to have people that weren't even responsible for those areas to come in and take a look at them, so that those other areas can assess it from an unbiased perspective and see what was written down and what wasn't written down, to be able to capture that information and have those conversations. Highly developed teams built around quality improvement processes and collaboration allows us to have those conversations that build upon the successes that we have and talk about the areas of improvement that we have available to us and map out a plan for it. It's a good feeling to be able to transition from the crisis of the day into proactive analysis and quality assurance systems, which is kind of what our hope is as we look ahead. So on January 30th, CMS and the White House announced that the public health emergency is scheduled to conclude on May 11th of 2023. In this, there's several information pieces that have been coming out, and I would anticipate that we're going to see more information coming in the upcoming weeks on how we can make these transitions and what we can expect. With the notice from CMS and the White House, the 1135 waivers have been updated as well, and gives us information on what we can expect to see happening excuse me, as we look for those transitions. So the CMS has provided an update of the waivers, of what the status of the waivers and when they will be transitioning through on this link, if you haven't seen them yet. So we'll make sure that we get that information shared out with you and you can take a look at that. But some of the highlights off of the sheet, just to kind of make sure that we're aware of this. The 3-day prior hospitalization waiver concludes with the COVID-19 public health emergency, the PHE notice. And so come May, we can expect to see at this point in time that the 3-day waiver will conclude. We'll see what additional information and resources come after that point. The waiver on the pre-admission screening and annual resident review concludes with the PHE. So we want to ensure that we are getting back on track and on process with the PASS-R screenings and the ongoing reviews that we have. There was an enrollment hotline established for isolation facilities that concludes with the PHE. And then expedited enrollment that was in place to allow providers to enroll with CMS. That has also be concluding May 11th as well. CMS will resume normal application processing times after that point. Interestingly, the NHSN COVID data surveillance reporting, there hasn't been any changes noted on this at this point in time. And we want to be mindful that the F884 citations may still be issued for facilities failure to submit the data timely. A few weeks ago, we talked about, we had gotten clarification on NHSN data and that CMS is monitoring that information. Facilities do have a 3-week grace period, but once that grace period is exceeded, then the fine will go back to the first week of noncompliance. So we want to think about how we have the NHSN data reporting in place. So we want to have our 3 levels of reporting people to back us up, and that those individuals have SAMS cards. It does take some time to get SAMS cards enrollment, so we want to ensure that we are working towards that. And don't fret if you do happen to be in transition in a facility where you have multiple users trying to get SAMS cards and trying to get back enrolled. Just keep your communication that you have, your attempts at enrollment, and where you've been following through on that. Keep all that information in a folder. So if you do get an F884 citation, you can look at the IDR process to submit and demonstrate that you are working through that. The more that we can prevent working in that reactive stage and be proactive in planning for backups and planning for having the need for support, the better off we are. So if you haven't started working on that multi-stage step backup reporting, you do want to have that in place. It just does assist with us. And once you have those in place, if you have any transitions of people in your organization, then the person that's able to report can add more people onto your building, and you can make that transition easier. Requirements to notify residents, representatives, and families of residents in the facility with COVID-19, including any new cases being identified, has been extended to 12/31/24. So you will still need to continue to report and share information with any new family of any new COVID cases in the buildings. I'm not sure that this is going to go away. And really, from an infection control perspective, and listening to what our survey team was telling us last week, it is a good practice to think about how we're notifying families and visitors and vendors coming into our building of what potential precautions that we want to have in place to help prevent that transmission of illness into multiple areas. So we want to be mindful about HIPAA. We want to be mindful about what we are communicating, but think about what those communication systems look like to ensure that we have that information. The alcohol-based hand rub dispensers, there was a waiver put into place on how frequently you could have them across the facility and how we were storing them. There is consideration because alcohol-based hand rub is very flammable. You want to be mindful about storing it in a manner that prevents or mitigates any issues with fire. But the placement waiver concludes at the conclusion of the PHE. So good opportunity for the environmental services team or the maintenance team to take a look at that from a fire code perspective, ensuring that any activities or anything that needs to be moved, we are considering this in conjunction with what's happening in our building and happening in the community transition rates, so we can come up with a plan on what our needs may look like or how we can adapt to ensure compliance with this changing guidance. We have the SARS COVID testing for staff and residents. The guidelines are applicable for the duration of the PHE and is applicable for 1 year beyond the expiration. So we'll see this still in place as testing guidance, cadence to ensure that we're mindful about mitigating transmission. Good information on this, and when you look at the 1135 summary page, it does give us a lot of information on what the status of the previous 1135 waivers were. It goes through and tells you when they change and even gives you the reference to any of the memos or guidance that was published, so that we can ensure that those are in place. So good opportunity to pull those through with your QAPI, run through them with your team, and ensure that all of your processes are in place and compliant with the changing guidance. I don't know about you, but the last several years, things have come so quickly at times and have processed so quickly that it was difficult to keep up on some of the changing guidance and the cadence. And so as I was running through the 1135 waivers the other day, taking a look, it was good for me as a reminder to say, oh, okay, yeah, I remember that had changed. And it'd be good to validate that this is actually in process, or did we update any of our policies or our forms, just to ensure that we remain that compliance. We anticipate that over the next several weeks and months, we're going to get more information as we continue to wind down from the pandemic. We're going to have information coming from the Vaccination and Related Biological Products Advisory Committee. They met January 26th to talk about what the vaccination cadence looks like and what can we expect from COVID vaccination and immunization in the future. There's several different pieces that were discussed, and we're looking forward to seeing what this might be in our future to make it a little bit more easy for us to manage and help with some of the confusion that we're seeing out in the communities of what understanding when we're up to date, when we're not up to date, what the differences between the different boosters, how do we manage this? So we're hoping that this is going to really give some clarification to all of us and help us operationalize this even better. I also think that, and we heard this last week and we're hearing this, you'll start to see some of the information being published, is that COVID we think is going to be with us. Jewel Coleman was sharing that with us a few weeks back, that this might just be one of the things that we deal with. Like we deal with influenza and we deal with norovirus. This might be one of those illnesses, viruses that becomes a part of our operational guidance. And so we want to ensure that we are mindful that this is still something that has negative impacts on people and can cause people to be very sick and or pass away in some circumstances. That's not always going to stop. Just like influenza can cause those same types of reactions or outcomes. But the more that we can include this in our operations, the more that we can just have this as what we do and are mindful about it, and our teams skilled at being able to respond, identify, and manage these needs in our facilities, the better off we're all going to be. And it lets us get back into operations as we had done them previously. Maybe not the same, a little bit different, but gives us back into the standard operations and out of the public health crisis. So we want to ensure that we keep infection control best practices learned during the pandemic as that opportunity to help mitigate the impact of future pathogens or future issues. I did a quick review to take a look to see where we're at. And as we look at survey readiness, this becomes a big focus for us. In the last year, since 2022, so all of 2022 and coming into 2023, which is October, November, December data pulling through from 2022 as the fiscal year changes, we saw that 25% of the providers were cited in South Carolina for F884 reporting for the NHSN data. So 25% of our providers have received that citation. Recall that there is a civil money penalty associated with that. This citation is managed by CMS. It does not actually come through on the survey team. This will be data that is 2567 will be sent to you directly for that failure to report timely. And there's a base rate that the facility will have been charged. And then with each additional failure or issuance of the 2567 is a $500 fine on top of that. So it grows by $500 each time this is submitted. So 2 years in, a little over 2 years of reporting requirements, it's possible that some people have changed in the organization or positions have changed over. So the facility may already have that base number have met and maybe in that upwards of $500 issuance as you go forward. So it's important to keep that in mind about the reporting cadence, but also, use the data for the benefit from a QAPI perspective. It's we know that there's a value from a compliance perspective, but we want to ensure that we also take credit for the value on the quality perspective and analyzing how our systems are functioning and what do we see happening. What are our results telling us, and how do we report that and review that with our team members? F880 had infection control. 19.7% of providers received that, with a total of 44 citations issued. F883, the influenza and pneumonia immunization tool, 5 citations were given. F886, the COVID testing of residents and staff, we had 3 citations issued. The antibiotic stewardship program, 881, had 2 citations issued. And F885, reporting residents, representatives, and families of COVID outbreaks, we had 1 citation issued. From a scope and severity perspective, I think this is the part that gets my heart pumping. In that same time period, we had, of the F888, F880 citations, 5 buildings received a K-level citation and 1 building received an L-level citation on their standard survey. And F886, 2 buildings received L-level citations on their standard survey, with F880 having 1 building issued a K-level tag on a complaint survey. These were all issued during that 2022 fiscal year period. So some pretty significant and high scope and severity citations issued with these tags. We want to be mindful of that the potential exists. And when we think about transitioning in from a survey perspective into those quality of care citations, maybe not infection control, but also thinking how the psychosocial grid is now going to be in play, and considering how we're looking at that harm level care, then that has the potential to increase our scope and severity as well. So good opportunity to pull this through, take a look at where we're at. We also have some data showing that while we are on the decline in South Carolina for infection-related hospitalizations, we also have some opportunity to take a look at and analyze our rehospitalization metrics and ensure that that's included within the infection control protocol, that we're reviewing what the opportunities are, that we're identifying any training needs, that we're reviewing resource needs, and including those with our education to our team members for the better outcome of our patients. We recognize when patients go to the hospital that may be unnecessary, they have higher risks of negative outcomes than people that are able to receive care in the community. So we want to ensure that we're recognizing changes in condition, that we're recognizing those treatments before things necessitate to the level of having to be transferred out. Or we may not always capture that, but sometimes there's opportunity that we can look at in our facilities, as well as to ensure that we're able to provide those services on site. We talked about some of the data that shows the value of this. Let's talk about what our tools are to help us maintain that survey readiness. Just as a quick question, how many people are utilizing your CMS pathways for infection control as part of your QAPI reviews or rounds? This would probably be a good time for a poll, but thinking ahead, we can look at that in the future. But for this particular meeting, if you'd like to type in the chat, or if you'd like to unmute yourself, are you using any of these tools? Have you found the value of them? Have you incorporated them into your practices? Oh, awesome, Heather. Do you have a best practice that you can share with us on how you incorporate the infection control pathway? Do you use it at certain time periods or as an ongoing? I see the value of doing this at times of outbreaks or times of crisis, and also as an ongoing tool. I've kind of heard and seen about it in both perspectives. So I'm so happy to hear that you're using this. Heather's team is using it during QAPI and at least quarterly. Very cool. That's a great best practice. Thank you. Anybody else have any information on how they're using it? Okay, feel free to jump in the chat or unmute yourself. So on the CMS website, and this is the link below, we'll send the slides out to participants after the meeting if you don't have this. When you click the link, there is a zip file you can download. And in the zip file contains all of the pathways that the surveyors use. Infection control is split into 2 folders. It's with all the rest of the pathways. It's also in its own infection control survey folder that lists out the QSOs that the survey team is referencing. It includes some of the entrance documents that we have for survey. And that's one of the tools that our survey team, regulatory officials from DHEC talked about last week, is allowing us as the providers, if we pull those survey entrance tools and we have our survey binder ready, that's going to allow us to manage the survey. The more that we can help to manage and predict and help our teams understand what's going to happen next, the more calm people feel. We're prepared for those outcomes, and we feel really good about navigating those transitions. So great tools to pull up and take a look at. I took some screenshots of some slides from our infection control tool. This case, it's the form's titled CMS 254, and it was updated October 26, 2022 with many of the phase updates that we saw in our SOMs. So we know that it's relevant and timely. There's a couple pieces on page 5 that we want to make sure as we go through the tools, if you've not taken a look at them before, the first page tells you, sorry, I should show you. The first page gives instructions to the survey team on what the purpose of this pathway is. And remember, for the pathways, when the survey team identifies who their population sample is, they're running through these pathways on every resident chart that they're going through, every patient chart that they're going through. And so as they're running through those, if the facility is having an area that the surveyors need to investigate further, the tool directs the surveyors to think about what additional considerations need to be put into place on this off of the SOM directions. It's based off of what the SOM intent is, as well as the descriptions in the underneath in that particular F tag. So they'll tell you how to prepare for it, how many people you need to talk to, what their observations should look like. And that's what the first several pages of this tool identify. On page 5, there's an observation component I thought was interesting. That the surveyors are going to observe staff to determine if they use appropriate infection control protocols when moving residents between rooms, units, and other areas of the facility. They're also going to interview appropriate staff to determine if they're aware of the process protocols for transmission-based precautions and how staff is monitored for compliance. So it's, as Elizabeth was saying, this is great to be rounding with, looking at tools on different components that were out there. Maybe we take it to that next level where it uses a tool as an opportunity to identify our shining stars in the building, get that morale pumped up. The last couple of years, it's been a lot of, not in all buildings, but it's felt like we've just had a lot of observations on the things that we aren't doing well. Let's flip the script. Let's celebrate, recognize our teams on the things that we are doing well. Recognize our shining stars, take their picture, give them a certificate. Have some candy bars in your pocket. Celebrate the things that we're doing well and building our team up and that engagement that we have. At page 7, think about, can our staff identify and describe the communication protocol that we have with local, state, public health officials when we have communicable diseases or healthcare associated infections, and how do we report potential outbreaks? And so they're going to be looking at the nursing team, the unit managers, and asking those questions. That's always good. If nothing else from COVID, one of the experiences I learned is, we could really lose a lot of people out with an illness at one particular time of the moment of the week. And so we want to have those backup pieces in place. We want to have people comfortable knowing what the expectations are. So regardless of who's in the building or who's not in the building, our protocols or our systems are in place to protect the outcome of our residents. We also want to ensure that our policies and procedures are reviewed at least annually. This one can get us not only from a regulatory perspective, a survey on the clinical side, but even on the emergency preparedness and the fire marshal side. So ensure that your team has a way to review and acknowledge every year your policies are still updated and still accurate. And that's usually a signature sheet or a process or QAPI that you're acknowledging that all your policy manuals have been updated. My last fire marshal survey that I went through, we got tagged because we failed to sign that the policies were reviewed and updated. Even though we had done the updates, we have to still sign and acknowledge those. Continuing on, the facility has established or implemented a surveillance plan based on the facility assessment for identifying, tracking, monitoring, and or reporting of infections, communicable diseases, and outbreaks. Interview staff and review a surveillance plan to determine how the staff monitors residents to identify possible infections and communicable diseases. This is good. It gets us out of COVID mindset. It's not just about COVID. There's other disease processes that our teams can be experiencing at any point in time. And we see that in our community spreads, and we are able to help mitigate those transition points. And so this is good to be able to talk with our teams and understand, how are we using our alert charting? How are we using our stop and watch systems? What's our handoff communication process? Are we seeing those changes? And it may lead into things like sepsis or other healthcare acquired infections that we can prevent a resident from having to go to the hospital for, and with a hopefully better outcome in some cases. Again, I give the caveat, not all things are preventable, but it's good to make sure our systems are in place to ensure the communications are there. We want to ensure our plan includes early detection, management of potentially infectious symptomatic residents that require laboratory testing, or implementation of transmission-based precautions, or even PPE. The plan may include tracking this information in infectious disease log. So what are our systems? There's been some nice updates with several of the EMR systems that you can include infection control tracking in the EMR systems. There's some really nice tools that are available for organizations to be using, different types of tracking systems and reporting systems in place. And many of you probably are already including this as your ICP tool to look at weekly or ongoing and reviewing at the QAPI meeting. And we want to ensure that the plan uses an evidence-based surveillance criteria, such as CDC and HSN long-term care, or revised McGreer criteria to define infections and the use of a data collection tool. I had a surveyor say to me last year, it's like what was old is new again. The McGreer's criteria is coming back. Things that we haven't really talked about since the pandemic started are things we need to just consider and ensure that our team is aware of what's in place, because these are COVID mitigation and prevention plans are just part of our infection control pathways, what we just need to have in place and our team able to manage as we look at all of the needs in the buildings. Under antibiotic stewardship, a lot of opportunity to refocus and validate our antibiotic stewardship program is in place. And we want to ensure that we are looking at written antibiotics. We have protocols in place. We're utilizing SBARs. Even Interact has some really great tools available to help us identify or manage through some of those infectious agents, like UTI assessments or recognizing sepsis. We want to have a process for periodic review of antibiotic use, and that our QA&A committee, our QAPI committee, is inclusive of several different disciplines to help us analyze and have a strong antibiotic stewardship response. Pharmacists is a fantastic resource that working with us on this, as well as our nursing team, our medical team, and our interdisciplinary team has the ability to help us with identifying changes in condition and ensuring that we have the pieces in place for that. We want to ensure that if there's any concerns with antibiotic stewardship, that we are investigating the use of unnecessary medication and the unnecessary medication pathway. This is what our survey team is going to be looking at. So, recognizing on UTIs, does the person have symptoms associated with a UTI? Are they symptomatic? Is it causing issues before we just run the treatment on it? Is there non-pharmacological interventions that we can be incorporating with these things? So if you're finding on your ICP reviews and the antibiotic stewardship panels that you do have these opportunities, ensure you're pulling that separate unnecessary medication pathway and running that through and feeling comfortable with what the results are. For ICP, we want to ensure that a facility has designated one or more individuals as the infection preventionist who's responsible for this facility's infection prevention program. There's a key in this that I think is so important and relevant, is we want to ensure that we have a designated ICP person, but we also recognize that we have a lot of staffing challenges and transitions that are happening nationally within our organizations. And so kind of think about succession planning for this. Sometimes we need to have an ICP, but then what if we have additional individuals that are back trained or cross trained into this on different shifts, or they can be our leads on this. And so we cross train those individuals and give them that training and that education. So we have our leads on other shifts that can help us with this program, that we're including them, but then we also can work on giving that training and recognition. So if something happens, whether it be somebody's on vacation, or someone has to take a medical leave, or someone wins the lottery and they have to go out of country to pick up their winnings, which we definitely wish for them. We're going to need to have that plan in place of who can step in and help us with this. It should not just fall on the director of nursing to be that person. Director of nursing is an amazing resource in our organizations that can help us with a lot of what we do. But that role can be a mentor to so many other individuals. And when we start to do the succession planning and cross training, we start to build that strength of knowledge deeper into our organization, and we can manage transitions and navigate those well. So I found that it spoke really highly to me about thinking how we can have our ICP program really set up and how we can really empower individuals. Now, Chris is saying that shift champions for ICP can make a big difference for us. So we want to consider that as you look forward in these programs. And where would we be if we didn't talk about and highlight influenza? So if you have not had the chance, or your team has not had the chance to ensure your influenza vaccinations program has been implemented, we have until the end of March. So while probably not the best opportunity, we want to make sure that those are administered earlier in flu season, we still have the opportunity to administer this out so that we can help for the safety and outcomes of our residents, ensure that if we do have a late season influenza outbreak, that they're better protected for it, and allows us to have that compliance. This data is reported out on the Nursing Home Compare site. It is one of our metrics that we have for quality programming. So we still have time to implement this. There is a benefit to it, and I definitely encourage you to take a look at it. Also think about the pneumonia, because I struggle with this word, I apologize. Also ensure your pneumonia tracking programs are in place. There's the 3 different types of pneumonia immunizations that can be given, and there's timeframes associated with it. So you want to ensure that you are looking at that system and that you are following the recommendations on how those should be administered. And you have a system to monitor for anybody that needs that next dose or qualifies for the next dose, that you have it in place so that you don't lose track of it. Okay. Before we continue, anybody have any other thoughts or comments about the survey pathway for infection control or unnecessary medications? Feel free to unmute yourself or type in the chat if you have any ideas or comments. Excuse me.
Looks like we've got a quiet crowd today.
Excuse me. That sounds like it. Whoops. I coughed and clipped through all these slides. My apologies. Okay, so another tool that we have available for the COVID-19 vaccination, this was updated recently on our HCLIN website. The link is below. This is a QAPI self-assessment tool that you can utilize that allows you to run through, am I ready for vaccination review? Have I done the necessary components related to our survey? And so in there, there's references to what guidance or regulation we have, so we can ensure that we're timely to this. For example, the second line is our organization has developed policies and procedures directing how resident or resident representatives are educated on COVID-19 vaccinations, such as the benefits and potential side effects. This is from this infection control pathway published on October 16th, 2022. And then below that, it says for vaccination requiring multiple doses, the organization has developed a process to ensure resident representatives again have received education on the benefits and potential side effects before being offered the vaccine. So it gives you the opportunity to write underneath there any comments or things you need to follow up on, and we can write it. Is this started? Has it just started? Are we on our way? Are we almost there? Or we're doing great with this metric? So good tool. At the bottom of the third page are quick link references that get you into different resources that can help you, from the QSOs, gets you to the link for the survey pathways, education to additional HQIN resources on motivational interviewing, or education tools or bulletin notices that can be posted out and shared with individuals, just to kind of give you an ability to tackle through that to make sure that you're ready. We know that Standard Survey is going to be reviewing the vaccination program for our residents. It will not review the staff vaccination program unless there's a qualifying statement on the first page of the infection control survey. So it will tell you when they're going to review the staff, staff vaccination. But at this point, this is mainly just for residents and resident responsible party notifications. We also have the HQIN resource on infection control that we wanted to share with you today. So when we're thinking about the rehospitalizations that we have in organizations, and we're looking at what our rehospitalization numbers are. That's a standard number that we're looking at with QAPI in most organizations. We recognize that it ties into compliance with our value-based programming. It's reviewed from our organization perspective on how we are supporting our communities, how we're partnering with our local healthcare providers. It also ties into recognizing changes in condition, ensuring we have the proper treatment in place, the proper diagnostics. We're documenting appropriately with the changes and recognizing needs in our medical records. All ties in from a compliance perspective. So when we're looking at rehospitalizations and we're analyzing the root cause of why people are going out, if we find any trends, we want to ensure that we're following through on those to prevent those future activities and those future transitions to the hospital. So one of the things that we see nationally as a big driver right now for transfers to the emergency room and hospitalizations relates to UTIs. Again, what was old is new again. We're talking about some of these things that we've talked about previously. So the HQIN website gives us, this resource gives us a UTI toolkit for long-term care facilities to use the evidence-based strategies for the prevention and management of UTIs in organizations. Things that we have from recognizing the change in symptomology, changing condition, ensuring that we're pushing hydration, that we're monitoring residents on a routine basis for those needs. All of those different components are coming into the UTI toolkit. So good resources available, good to have those with your team. Most of these tools complement very nicely with corporate policies and procedures because they're evidence-based. And so this is not meant to replace anything you may have in your organization or from your corporate guidance. It's meant as just another resource in your back pocket to use that might be able to just change the look of an education out there, maybe change the look on a bulletin board and supplement what you're currently doing. We also have the sepsis toolkit for skilled nursing and long-term care and screening tool for sepsis, and an education brochure from HQIN on educating families on sepsis. There's a great resource about helping families understand the benefit of do they have to go out to the hospital, and the decision-making guide. So those are wonderful resources to have, again, in your toolbox of documents to be able to educate your families and help them through any of these conversations. A resource tool here at this link that's in hot pink, the NHSN HPS flu vaccination protocol. For quality reporting, our Centers for Medicare and Medicaid Services published the final rule in August of 2022, requiring that we report the number of healthcare professionals that have received influenza vaccination during the 2022-2023 influenza season. So if you have not offered the influenza vaccination to your staff, again, you still have time to do that before the season's over. Identify what your needs are, come up with your plan, talk with your pharmacy, and implement the influenza session so that you're able to ensure your staff are protected during the influenza season, even this last several weeks, but also ensure that we're compliant with what the expectations are. So ensure that you take a look at this and that you're ready to report those numbers out at NHSN. The CDC gives us some protocols on what they suggest for how organizations can implement this into their reporting practice. So wanted to ensure that we talk about that today before we get too much further to the conclusion of the influenza season. And as everything we've talked about really centers around the quality assurance process improvement functions, the QAPI functions, you will have received in your mailbox this week, I think it came in on Wednesday, from Chris Williamson and her HQuinn email, a newsletter about QAPI and the QAPI program. The QAPI guidance was updated in October of 2022, so this is something that we are seeing an increased focus on with this new rollout in the SOM, and a good opportunity for us to really validate that we're utilizing our QAPI committee to the benefit that it has to us. As we do our walking rounds, we do our huddles, we're working through that flow of communication on our report sheets, ensuring that we're not only getting information into our review committees from our floor staff, but that we're sharing that information back out, and that we have that flow of communication occurring back and forth. When we identify opportunities, it gives us our baseline data to do research, determine if it's a much bigger opportunity in our systems, and if so, review our policies, review our procedure guide, talk with our team about what's not working, develop our education, roll it out, and then do our metric to determine if we've made the impact on it. It's QAPI 101. And so this email was a really nice summary of some of those functions and those formats that we can utilize in our QAPI communities, committees. And it ties into what we talked about today, really assessing where we're at and using that as our baseline to not only develop our plans for process improvement, but when we assure the quality, that we take the time to celebrate with our staff. And we include that into the things that we're doing really well. We want to make sure that when we include that in and we build that excitement, it helps to build that morale. And when we have happy employees, that rolls into happy staff. And happy residents and happy families. And we all start feeling good about what we're doing. We need to have those moments, and they've been few and far between in the last several years for many of us. So definitely want to encourage that. Want to open it up and best practice sharing our questions that we have. Any comments, questions, concerns, things that you'd like for future sessions. We'll open the conversation up. Feel free to unmute yourself, type in the meeting chat, whatever's on your heart and mind.
This is Chris, and I just want to thank Alyssa for putting all the time into this that she has this week. I was really excited to hear this particular meeting, because there are a lot of things that we've been so focused on COVID that those things kind of just got stuck back there in the dust, you know, and those things are being brought to the forefront. We've got to take a look at them, and we've got to make sure that we're doing all those old things that, you know, we may not have thought about in the last little bit. So thank you for that. Again, we encourage you to speak up and let us know if you've got some really great ideas that are working in your center for something, and share that with us. Or if you've got a question as to how you might pull something off because you've got a challenge that somebody else may be able to assist you with.
Well, thank you, Chris. That's very kind of you. And I completely agree. Let's open it up to our DHIC team members that are here with us today too. If you've seen anything that's been that spoke to your heart, or any best practice that you'd like to share. We'd love to hear from you. We've got so much expertise and talent on this call today, so definitely open and curious on what thoughts you have. Okay, well, feel free. I'm not gonna, we still have time to talk and we still have time to chat, so feel free to jump in, but definitely want to ensure that we are promoting our next session next week. We're going to be talking about roundtable discussion on strategizing for staffing and some of the staffing challenges that we're seeing. There's some resources that I'm finding. I'm still trying to confirm one of my speakers, but if nothing else, we will start to talk about one of the biggest elephant in the room conversations that's happening across the nation is staffing. So bring your ideas, bring your questions, and we can get, if nothing, we can get some really good foundation for how we can develop future series and education out on this. But hope we can share some good, some tips and techniques. There's also a promotion from CMS that came out. If you're interested, on February 14th, a wonderful way to celebrate Valentine's Day is to jump on the CMS call at 4 o'clock. They're going to be talking about, it's a special roundtable to talk about the improved COVID-19 booster rate and use of therapeutics. I'm impressed with the number of facilities that we've been talking to that have really incorporated the therapeutics within center operations at their organization. We've had some good best practice conversations on these previous calls. So I'll be jumping on to the CMS call just to kind of hear what else we hear is happening across the nation, if there's other tools and resources available. But it's a free call. Because it's national, you definitely want to make sure you're registered for it and that you do jump on about 15 minutes beforehand, because it starts to get blocked up right before the meeting and it's hard to get in because of the queue that they're processing. So just as a little tip from previous meetings I've attended, that you just want to plan ahead on that. Okay, and we are coming up on our hour. So if you have questions or thoughts, feel free to jump in. Otherwise, we'll stop the recording and stay on the line for a few more minutes for any other conversations that we need to have.